Good morning, dear friends. So now the second keynote lecture by Dr. Gangadhar Sundar. He is the head and senior consultant Orbital and Occupational Surgery at the National University Health System, Singapore. He is currently the president of Singapore Society of Ophthalmic, Plastic and Rhinologists Surgery. He is a member of International Advisory Board, Tamil Nadu Ophthalmic Association Journal Scientific Research. And now I invite Dr. Gangadhar Sundar to deliver the lecture.
Thank you, Chairperson, and good morning. Big thanks to the local organizing committee, Dr. Balakrishnan, Narayan, and the entire ENT community respecting India. After such a brilliant talk, now I know two brilliant Jayashankars in India. You know who the other person is, right? He actually emphasized the role of this neurosurgeon ENT collaboration to deliver the best result possible. So I, on behalf of the ophthalmology community and the ophthalmoplastic community, would like to share my perspective on the close relationship that I have with my colleagues. Very well. So these are some of my disclosures. I do a lot of trauma work, a lot of thyroid work. I do a lot of multidisciplinary craniofacial trauma work as well as oncological work. And we work, as Dr. Jayashankar showed, part of a multidisciplinary team for various complex disorders that we see not just in the eye, but around the eye in the orbit and the midfacial skeleton. So my talk is going to cover a little bit about what is orbital and oculoplastic surgery for those of you who are not yet completely familiar with it. The relationship between rhinology and orbitology from our perspective. Basically, most of my talk is going to be a bunch of cases, illustrative cases showing the value of this great collaboration. And finally, address the real difficult part. What are the barriers for these collaborations and suggest possible solutions? No meeting in South India, no meeting in Coimbatore can happen without really recognizing some of the greats in the field. That's Dr. Shanmuganagan, the former chairman of Ganga Hospital. Coimbatore is well known for it. And Professor S. Kameshwaran, ENT professor whom we all know indirectly trained with. And they have heavily influenced a lot of my thinking and thought process over the years, and I'd like to pay tribute to two of them. If you look at my professional journey, the Red Fort, some of you may recognize the Madras Medical College, where we had practically every subspecialty in ophthalmology and medicine. And after I finished that, I went on to the Government Ophthalmic Hospital, which is a standalone ophthalmic institution completely disconnected from the other subspecialties. But when I finished my residency and went on to my fellowship in the United States, I went to Henry Ford Hospital in Detroit, which again was a classic multi-specialty hospital where the neurosurgeons, the ENT surgeons, the cranial maxillofacial surgeons were all next door if we needed to collaborate. That's the first time I got a real exposure to the opportunity of collaborating with our colleagues. And then I went and joined Shankar Netralia when I came back again, a standalone ophthalmic institution. When we started seeing complex work, we used to invite specialists. Dr. Tulsi Das, for example, was a big name in ENT in Chennai. Then Dr. Mohan Kameshwaran was there. So we had complex cases, we were bouncing off these cases. This is what impelled me to say that the future of orbit should be a collaborative relationship. And that's where right now I'm at the National University Hospital Singapore, where we function essentially as a multidisciplinary team for complex reality as well. And this is what has impelled us into training fellows from about 14 countries. Each one of them have been doing some good job as well. So quick overview of oculoplastic surgery. We deal with eyelid surgery in children and adults. We deal with lacrimal surgery, which is where again the rhinologist comes in. And we deal with orbital surgery, where we manage pure intraocular diseases. But there are orbitofacial diseases and sino-orbital diseases where the rhinologist also comes in. Apart from the functional work we do a lot of aesthetic work as well. Total facial rejuvenation, browlers, blepharoplasty, mid-face lips. And this also enhances the quality of life of some other patients. So we look at orbital specialty as such. We deal with congenital craniofacial deformities. We deal with orbitofacial trauma, inflammatory disorders, neoplasms, which are arising primarily within the orbit or outside the orbit, structural deformities, and vascular anomalies. This is one specialty where vascular anomalies is now lending itself to multidisciplinary management. So orbit, as you know, is the most important structure in the mid-facial skeleton. There are two of them, causes the eyes next to the brain and the heart. We'd like to think that the eyes are the most important. But interestingly enough, if you look at the anatomy over there, the orbit is beautifully surrounded by the paranasal sinuses. The maxillary sinus, ethmoid, sphenoid, and the frontal sinuses. And that gives you a beautiful opportunity to collaborate with the rhinologist itself. Not only can you approach your orbit through the paranasal sinuses, diseases in the orbit oftentimes spread into the sinuses and may present to you. Likewise, diseases in the sinuses arise and present to the ophthalmologist as a proptosis or intraocular anesthesia. And that's where this collaboration really comes in. And lately what we've been doing is just, Jayashanka was talking about using the paranasal sinus as a pathway to get to the vital structures, the pituitary fossa, for example, the orbital floor, orbital medial wall, or the apex of the orbit. And that's what I'm going to be talking about in this presentation today. So let me showcase some examples of paranasal sinus diseases which affect the orbit, classifying into infections, which can be bacterial, viral, fungal, so on and so forth, neoplasms, which could be benign or malignant, and finally the interesting disease of silent sinus syndrome. Here's a child, as you can see, proptosis, limitation of movement, fever, headache, pyrexia, orbital cellulitis, no brainer. Welcome, Dr. So, orbital cellulitis, but a fraction of these kids and adults end up with a subperiosteal abscess. The natural tendency is to go in and do the functional endoscopic sinus surgery in an acute situation. Now, in children, we tend to medically manage them, and there are certain criteria to downgrade these subperiosteal abscesses. As you can see over here, you can now treat these patients medically and, when necessary, drain the subperiosteal abscesses. So the take-home message for rhinologists working with ophthalmologists, there are specific indications to drain these subperiosteal abscesses in children, and hence a non-responsive subperiosteal abscess is what you should be really dealing with when there is no response to conventional treatment. Here's another adult patient who presents with no light perception in the eye in an acute orbital syndrome. You can see the acute proptosis, but if you look at the scan over there, shows is pathology arising from the frontal sinuses. This is an acute abscess arising from a frontal sinus mucosa, where you do the emergency drainage or doing an orbital abscess drainage, followed by functional endoscopic sinus surgery and frontal sinus abscess drainage, so that you are returning vision at the same time addressing the primary pathology itself. Yet another example of acute infection of the paranasal sinuses affecting the ophthalmology territory. Here's a child from the Middle East who was referred to us because of a swollen enlarged muscle, rhabdomyosarcoma, 5-year-old child, proptosis. But what the referring physician failed to recognize is, if you go back in the orbit, there's some paranasal sinus involvement itself. So we know a rhabdomyosarcoma does not arise from the extraocular muscles. So you know that in pathology, you go back and do a biopsy, and what do you see? Fungal elements. This is nothing but a fungal sinusitis with secondary orbital involvement. Yet another example of a paranasal sinus pathology with secondary orbital involvement, which, as you all know, can be medically managed very well. And of course, I should not be talking to Indians about rhino-orbital cerebral mucormycosis. I think you had a deluge of these cases, and each one of you were really the warriors handling these patients in the acute situations. Yes, we did lose a lot of patients, but he also contributed a lot to literature about aggressive management, if necessary, even exemplation for these patients. But what we are now dealing with is the residual aspect of post-exemplation deformity survivors of ROCMs who are now awaiting reconstruction. That's now the new goal in targeting treatment for these patients. In summary, infections, one way or the other, of the paranasal sinuses can affect the orbit, and hence having that close relationship is very important. The next series of cases I'm going to showcase are sinonasal tumors, which can be benign or malignant. Here's a young dentist from Brisbane who actually started noticing her left eye was shifting up. She developed a little fullness of the cheek, but no paresthesia whatsoever, no motility disorder, no visual loss. If you do an imaging, again, a tumor, space of primation, and maxillary sinus, I can see the entire floor of the orbit displayed superiorly, causing the proptosis. This is a case of a myxoma of the orbit, where we have done a complete resection, a maxillectomy, followed by reconstruction with return to normal. Examples of benign tumor. But more often than not, we see malignancies, lacrimal sac carcinomas, sinonasal carcinomas, and sinonasal, even melanomas, which is supposed to be a very aggressive form of melanoma compared to the cutaneous melanoma or even the choroidal or uveal melanoma. Here's an example of a patient who also has paresthesia, proptosis, some amount of visual loss. I can see invasion of the floor of the orbit from the maxillary sinus. Historically, these were all treated with maxillectomies, not just maxillectomies, because orbit is involved in exoneration as well. Here's an example of a patient who presents with a supranasal mass with proptosis and paresthesia is actually a squamous cell carcinoma of the frontal sinus causing a proptosis and an ophthalmic presentation, not a paranasal presentation. In the past, we treated these patients with an aggressive maxillectomy, preserved the eye when liquid, and accepted this as the standard of care. Patient is living, patient is saying that's acceptable.
From my NUHS depot, we have talked about the teamwork in front of our God in this appreciate course. More options are here. So it's great. Teamwork is very, very important. At the same time, for the juniors, the cadaver dissection is also very important. I think so. Okay, it's a great lecture. Thank you, sir.
Thank you very much.